Welcome to this council meeting where we'll be discussing about one of the key challenges faced by the Hertfordshire County NHS, which is misdiagnosing the delirium as dementia, and which has led to increased patient occupancy and reducing the efficiency of the NHS. So I'd like to welcome the panelists who are present here, which is Mr. Kesan Subramani, who is the Hertfordshire Council lead member, and Mr. Niral Bharatbhai, who is the clinical director of operations within the NHS, and Ms. Vishali Merin Albert Leo, who is the human resources manager, and Kavya Venkatesan, who is the clinical director in the NHS, and myself, Ajit Ankaswamy, who is the financial manager in the NHS. So I'll give a basic overview of delirium and dementia and what's happening within the NHS in the Hertfordshire. So dementia is basically a memory impairment which happens due to various reasons, such as vascular factors such as hypertension, diabetes, stroke, hyperlipidemia, etc. And many of the reasons such as age-related thing like the Alzheimer's dementia and the Parkinson's related Lewy body dementia and the frontotemporal dementia. But this delirium is a different thing. The delirium predisposes to dementia, but delirium itself is not a dementia. It is due to many other risk factors such as underlying urinary tract infection, dehydration, change in environment, old age, multi-comorbidities, chronic conditions, recent surgeries, etc. So what happened is people are misdiagnosing this delirium as dementia, and this is increasing the bed occupancy and impacting the funding wastage in the NHS. This is mainly due to the workforce shortage and the time constraint of the availability of the clinicians and the inefficiency in training of the frontline workers, not able to differentiate dementia and the delirium. So because of this race boundality phenomenon, people are working in a time constraint, high pressure environment, taking easier judgmental thinking way, and they're diagnosing more dementias and leaving this delirium per se undiagnosed. So what will happen is more people are diagnosed with dementia and they occupy the bed for more time. And one person, if he occupies the bed for a day, it costs around £500 for the NHS. So if they occupy for 10 days, it's £5,000. So if there are more than 100 persons or 200 persons like this, it significantly impacts the revenue on the bed clearance time. So this could well go beyond around £500,000 per year. So if we are able to train the staffs, then we could develop some assessment tools like confusion assessment methods, train the staffs and the clinicians through the clinical assessment method. This could reduce the funding shortage and improve the efficiency. So now I am open to the discussion with the panelists, and they could ask their queries from their perspective, and I am open to the questions now.
Yes, Ajit, I can hear you. I have a question. You are saying that dementia, delirium is misdiagnosed as dementia, and what if it's been diagnosed as vice versa? Because most of there is a statistics of dementia care 2023 about there were 6 lakh dementia care patients in UK, and out of that 20 to 30% were people were misdiagnosed, and also they were been diagnosed lately. You are saying that delirium is misdiagnosed as dementia, and if you are um, treating all the patients as delirium or treating all the patients seeing in the aspect of delirium, the care will be reduced, right?
Yes, Mr. Kesan, that's a very good question, actually. So what you're saying is, if we prioritize diagnosing more dementia rather than like delirium more than rather than dementia, you'd be underdiagnosing this dementia thing and overdiagnosing the delirium. That's a greater possibility to happen. But for that not to happen, we should train our frontline workers and the clinicians and staffs who are involved in the decision-making process with proper continuing professional development courses and training them in the with the appropriate tools like the confusion assessment method. So in this way, we will be reducing this chances of overdiagnosing the delirium thing and underdiagnosing the dementia thing. So what I think is we have to train them efficiently so that we would be saving actually rather than overspending and making it more worse than this.
Thank you, Ajit.
Also, I have a question to you, Mr. Rajat. And once again, thank you for the wonderful talk with the finance perspective. So, with respect to the financial constraints, how do you justify investing on delirium screening when the financial budgets are already tight? So, does that affect the quality of treatment you provide to the patients?
Since we follow a targeted approach and evidence-based approach, what we can do is we can implement it slowly on a phase-based manner where we'll be looking after the outcomes, and based on the outcomes which we receive upon the proper training and the like how it is impacting the NHS in a financial way, then we can stepwisely, incrementally do it expand it in a phase-wise manner. So we won't be compromising on the quality of care, as well as we'll be saving our budget and money, and we can increase our productivity and the efficient nature of diagnosis without impacting the care. Is that answering your question, Ms. Kavya?
Yeah, thank you for your perspective.
Thanks, everyone.
Hello. Good morning, everyone. Today I will discuss the role of the Director of Operation and operation challenges affecting healthcare services across the Hertfordshire. As the Director of Operation, I will discuss an important healthcare challenges shown in this scenario. Delirium being misdiagnosed as dementia. In this case, an elderly patient arrives at the hospital with confusion. Instead of investigation the sudden change properly, the patient is immediately labeled as having dementia. Because of the condition is treated as a chronic illness rather than an acute medical emergency, the patient's condition worsens. This scenario highlight a major operation problem with healthcare systems. One key issue is delay assessment and diagnosis. In busy healthcare environment, staff maybe take rapid inception due to time pressure, workforce shortage, and overcrowded issues. When patient flow is high, there is a risk that acute conditions are overlooked. Another operational challenge is poor communication between departments and care teams. If information is not shared effectively between emergency department and ward staff and other staff and specialists, important clinical signs may be missed. The scenario also demonstrates capacity pressure with healthcare organizations. High patient demand and limited staffing can reduce the time available for proper assessment and monitoring, especially for elderly patients with a complex condition. As the director of operation, improving patient safety and service coordination is extremely important. To address these issues, several operational improvements can be introduced. Firstly, healthcare organizations should implement standardized assessment pathway for elderly patients presenting with confusion. Staff should automatically screen and delirium before diagnosis dementia. This creates consistency in care delivery and reduce diagnosis error. Second, digital triage and alert system can be help staff identify high-risk patient quickly. Electronical systems can flag symptoms linked into delirium, infection, or sepsis, ensuring patient receive urgent attention.
Okay, Narel, thanks for your insight. It was really good. I just have a question for you. My question is like what workforce related factors like such as staffing levels, workload pressure and training gaps contributed to the misidentification of delirium as dementia, and how can we strengthen staff capability and escalation processes to prevent this type of diagnostic error in the future?
Yeah, thank you, Vishali, for asking the question. Workforce related factors played a key role in the misidentification of delirium as a dementia, particularly in a high pressure hospital environment. Firstly, staffing shortage and an imbalanced skill mix reduce the time and expertise available for proper assessment. When wards are understaffed or rely heavily on junior staff, there is a higher risk that sudden changes in cognition are not fully investigated, leading to inception rather than clinical confirmation. Secondly, high workload and time pressure contribute significantly in busy acute settings. staff may prioritize immediate physical care needs over detailed cognitive assessment. To prevent this type of diagnosis error, several improvement can be made. Staff capabilities should be strengthened through mandatory training on delirium recognition and use of standardized assessment tools. Overall, addressing these workforce issues can significantly reduce misdiagnosis and improve patient safety. Thank you.
Okay. Thanks for your perspective, Niral.
Hi, Niral. This is a
Yeah.
follow-up question from what Ms. Vaishali asked just now. So can we use AI for assessing the patients earlier in the emergency setting and transferring the data from the emergency setting and passing it on to the ward so there is no lag? And this saves time and financial cost as well. This is a global trend which is happening in healthcare. Can we do it? What is your perspective on this, Mr. Niral?
Yeah, thank you, Ajit, for asking. Poor communication in emergency wards can be improved using AI and faster digital data transfer system without delaying patient care and safety. Firstly, AI-powered electronic health records can automatically summarize and key patient information such as allergies, medications, and previous conditions. This helps clinician assess critical information quickly during emergencies instead of searching through long records. Secondly, integrated digital systems can improve information sharing between ambulances, emergency departments, and hospital wards. This means staff can prepare in advance before the patient arrives, reducing delays in treatment. Overall, using AI for real-time alerts, automated summarize, and seamless data sharing can significantly improve communication, reduce delays, and enhance patient safety in emergency departments. Thank you.
Thank you for your valuable insights, Mr. Niral.
Chair members of Hertfordshire Local Area Partnership. So, as a clinical director, my main responsibility is to ensure safe, good quality, effective clinical care. So, today I'll be highlighting the critical patient safety issue within our system with respect to the misdiagnosis of delirium and dementia. So, what are the key clinical challenges with respect to patient safety failure is diagnostic inaccuracy under pressure. For example, delirium is said to be an acute reversible condition, whereas dementia is a chronic progressive disease. So what happens is it has mainly serious consequences, such as there'll be delayed treatment of underlying causes, as a result of which there'll be increase in mortality. At the same time, as Ajit had highlighted, there's more hospital length stay. So as a result of which the patient trust is lost and there's reduced service uptake. So this results immediately in workforce shortages, and at the same time, the care is said to be fragmented in different perspectives. So as a result of which, the clinical capacity and the time in diagnosing is going to be very much inaccurate and it's reduced. So I would like to apply certain theories with this, which evaluates healthcare quality across 3 domains, which is mainly we are currently facing staffing shortages, and there's not necessary training in recognizing the delirium. And there's always an inconsistency in the cognitive assessment method and lack of standardized delirium screening protocols. So improvising this will improve the diagnosis of delirium. So which results in poor patient outcomes and avoidable deterioration, and there's more burden on the NHS. So what are the strategic risks if they are unaddressed? So there's more of hospital admissions, readmissions, more financial burdens, and at the same time, there is health inequalities and decline in patient trust. I would like to reiterate on the patient trust and the healthcare services, there's long waiting times. So the recommendations would be, mainly from as a clinical director perspective, is the clinical prioritization model, which is the safety first approach should be preceded. So more acute reversible conditions should be addressed first, which will improvise on the outcomes. And at the same time, better screening pathways, such as the 480 screening tool across all clinical care settings, and integrating the communications between hospitals, GPs, and the community services, such as the ICS model. So, which in turn utilizes the transformation leadership to engage and empower clinicians and reduce the service overload in a phased implementation and a pilot testing manner. So, the inequality in access to improved pathways will basically target the community outreach and the inclusive service design. So, my recommendations would be the ICS and the public health model by focusing on the early detection and prevention and the need for sustainable health quality care under financial constraints. So it's just not a clinical error, but it's a system level failure which addresses the issues in structure, process, and the workforce capacity. Thank you.
Kavya, Ms. Kavya, you have been told that as a clinical director, what's your best advice for the GPs you can give in diagnosing the patients with delirium and dementia?
I think as a clinical director, my main point would be addressing the condition because delirium is a short term and it's a reversible condition, but a dementia is a chronic and progressive one. So probably using the effective screening tools, diagnosing them earlier, and at the same time providing better quality care, finding out the underlying causes of delirium because there's several factors which cause delirium. But dementia, it's going to be a very broader term. It can be either Alzheimer's or Lewy body dementia. But delirium can be either because of an infection, it can occur in elderly individuals. And at the same time, what you should do is you should be aware of the diagnostic tools, not only the screening tools. Once you screen the patient, I think providing a better diagnostic investigation would enhance a better patient quality outcome. So I think GPs who are at the first hand would be in a better position to do that. Am I answering your question, Kesman?
Yes, Kavya. Thank you.
Thank you.
Yeah. So Kavya, I would like to ask one question. As a clinical director, what key performance indicators would you use to measure clinical effectiveness and safety?
So as a clinical director, probably my role would be in finalizing what is the outcome, key performance indicators, which would be the probably the mortality rate of the patients or how long they are in the hospital, what are the outcomes, readmission rates, and it can be in process key performance indicators or structural. So I think with respect to process, it could be the early diagnosis, as I had mentioned earlier with respect to GPs. And at the same time, structural could be what is the staff versus patient ratio. Like for 10 patients, there should be at least one staff for a better patient um, healthcare quality. And at the same time, the satisfaction and the trust of patients with respect to diagnosing earlier and a better service to them without a long waiting times. I think these are the key performance indicators I would suggest as a clinical director from my side. Did I answer your question?
Yes.
Thank you, Nidal.
Thank you, Kavya, for your wonderful insights. And with this key performance indicating parameters in place, we could actually track the progress and allocate the funds sufficiently if it's working or not, so that NHS flourishes and works efficiently and in a better way. Thank you so much.
Thank you.
Good morning, chair members and members of the Hertfordshire Local Area Partnership. As the human resource manager, my role is to ensure that our workforce is not only sufficient in number, but also skilled, supported, and capable of delivering safe and high quality care. Today, I will highlight how the misdiagnosis of delirium as dementia is not just a clinical issue, but a clear reflection of workforce challenge within our system. Let me begin with a brief example. An 80-year-old patient was admitted with confusion and agitation. Due to time pressure and staff shortages, the condition was quickly assumed to be dementia. However, within 48 hours, the patient's condition deteriorated and was later identified as delirium caused by infection and dehydration. From a clinical perspective, this is misdiagnosis. But from an HR perspective, it highlights the pressures staff are working under, how these directly impact patient safety. There are four key workforce challenges contributing to this issue. Firstly, staff shortages and high turnover mean that healthcare professionals are often overstretched with limited time to carry out thorough assessment. Secondly, there is a training gap. Not all staff feel confident to distinguish delirium from dementia, particularly in high pressure environments. Thirdly, staff burnout and fatigue affect concentration, judgment, and decision making, increasing the likelihood of errors. Finally, poor communication and lack of patient baseline information can lead to incorrect assumption, especially in fast paced settings. To address these challenges, I can draw on Herberg's two-factor theory, which emphasizes the poor working condition and high workload reduce motivation and performance. In addition, adopting transformational leadership can help create a supportive and positive culture where staff feel valued, engaged, and empowered to deliver safe care. From an HR perspective, I recommend four key actions. First, implement mandatory delirium training and continuous professional development, ensuring staff can recognize and respond to early symptoms. Second, improve workforce planning, moving from reactive staffing to a more proactive approach that ensures staff staging like levels and the right skill mix. Third, introduce staff well-being initiatives such as mental health support and flexible working to reduce burnout and improve overall performance. Finally, strengthen multidisciplinary communication, ensuring teams share information effectively and make informed decisions about patient care. However, these are some risks to consider. Staff may resist additional training or changes in practice. This can be addressed by involving them in decision making and program design. Financial constraints may limit resources, so it is important to focus on cost effective solutions, particularly those that improve staff retention. In conclusion, the misdiagnosis of delirium as dementia is not just a clinical error, it is a workforce issue. As a human resource manager, my focus is on building a workflows that is skilled, supported, and resilient. Because ultimately, when we invest in our staff, we improve more patient safety, enhance care quality, and ensure the long-term sustainability of services. Thank you.
Thank you so much, Merin, for your valuable insight as a HR manager. So my question would be, what training would you provide for healthcare professionals in order to provide a better clinical outcome and a patient safety aspect?
Okay, yes, I would implement a target and a continuous training program focused on both clinical competency and decision making under pressure. So, firstly, I would introduce a mandatory delirium awareness training, ensuring all staff can accurately distinguish between delirium and dementia. This would include use of recognized screening tools such as 480, which supports rapid and effective assessment in clinical settings. Secondly, I would provide clinical assessment and critical thinking training, helping staff safe decisions, particularly in high pressure environments where quick judgment is required. And also, I would implement communication and the multidisciplinary team training, such as structured handover techniques to improve information sharing and reduce errors caused by miscommunication. In addition, I would also include continuous professional development programs, ensuring staff regularly update their knowledge and skills in line with best practice. So, also, I would support with simulation based trainings, allowing staff to practice real life scenarios like delirium cases in safe environments, improving both confidence and competency. Overall, the aim is to create a workforce that is not only clinical skilled but also confident, responsive, and able to deliver safe, high quality, ultimately leading to better patient outcomes.
Thank
Thank
you
you,
Is
so
it
Vishal.
okay?
much.
Yeah.
It was wonderful and great insight.
Thank you.
Thank you, Vishal. I would like to ask one question. How
Yeah.
would you measure staff performance without increasing pressure on already stretched teams?
Yeah, like I would focus on balanced and development approaches rather than strict performance monitoring. So I would use existing data such as patient outcomes, incident reports, and audit results instead of introducing additional reporting tasks. This avoids adding extra workload while still providing insight into performance. I would also implement regular but supportive appraisals where the focus is on development and learning rather than judgment. This aligns with Herberg's two-factor factor theory, ensuring staff feel supported rather than pressured. And I also encourage team based performance measurement instead of focusing only on individuals. This promotes collaboration and reduces blame culture, which is important in healthcare settings. In addition, I would also introduce 360 degree feedback where staff receive input from peers and supervisors in a constructive way, helping identify strengths and areas for improvement. So this improves leadership support, particularly to transformational leadership is essential to create a culture where feedback is seen supportive rather than punitive. Yeah, is my answer.
Sorry, Nirul, you are on mute. Can you just unmute and just express yourself?
Thank you. Thank you for your perspective.
Thank you, Nirul.
Hello everyone, I'm Kesan Subramani. I'm the playing role of Hertfordshire County Council lead in the health and well-being. And I will now take you through the key challenges I face in this role, the recommendations I am proposing, the risk involved, and the strategic framework that guides my decision. Let me begin with the key challenges. There are four main key challenges I am facing with. The first key challenge is the financial pressure. Because of austerity and rising inflation, the council has significantly less money to work with. But the demand for the health and the care services is increasing. We have to do more with less. That creates the real pressure on the capacity of services. The second challenge is the fragmented service delivery. Different organizations such as NHS, the council, the charities, and the community services are not working together efficiently because they operate separately. Patients often fall through the gaps and they don't receive the joint of care they needed. The third challenge is the health inequality. Not everyone in the Hertfordshire has equal access to healthcare. People from vulnerable and deprived communities face more barriers to getting care and as a result. Their health outcomes are significantly worse. This is not acceptable and it has to be addressed. The fourth, the lack of prevention focus. Right now, the system spends most of its energy treating people who are already seriously ill, rather than catching problems early and preventing them in the first place. This is driving up long-term demand in a way that is simply not sustainable. The recommendations to address these challenges, I have 5. The first, implement joint budgets across all the L&Hm partners. Second, invest more in preventive and early intervention services. Catching health problems early is far more cost effective than treating people after the condition has become severe. Third, strengthen the integrated care partnership between health services, social care, and community organizations. When these three work as one, patient experiences a smooth, connected service rather than a confusing and fragmented one. Fourth, the community outreach. For increasing community outreach programs, especially in deprived and unreserved areas, services cannot just wait for people to come to them. We need to go where the need is greatest. And last, the fifth, engage local communities in co-design of services, where communities help shape the services they use. There is a great trust, better engagement, and ultimately better health outcomes. On the risk mitigation, the first risk is budget deficit. Its funding falls short, we will not be able to implement these improvements effectively. The second risk is poor coordination between agencies if the organization fail to communicate and collaborate properly. And the third is the low community trust. If the people don't trust the health system, they simply won't engage with it. To bring everything together, prevention, integration, and shared responsibility are not optional extras. They are absolutely essential. We want to build a healthcare system in Hertfordshire that is sustainable, fair, and it fits for the future. Thank you very much. That's it. I'm open for question and answers.
Okay, Kesavan, I have a question for you. First of all, thanks for your insights. Like, my question is, how can workforce deployment be improved to reduce health inequalities across different population groups?
Yes, we will implement a grow your own strategy model and shared staffing banks to ensure local, cultural, and competent staffs. They are deployed directly into undeserved hotspots identified with public health data. By strengthening integrated care system ICS pathways, we can transition from a reactive model to proactive community-based care. Did it answer you?
Yeah, thank you,
Okay.
Keshavan.
Thank you. Is there any
Hi.
other questions?
I'm-
Hi, Ajit.
I have a question for you.
Sure.
So my question is, since we are dealing with limited funds and we have some deprived as well as vulnerable groups where there is inequality in access and reach and trust for the care which we are providing. So what can we do to maximize our reach to that vulnerable group and improve their access and trust on the NHS system, since there is a issue ongoing with the disparities in the quality and the access for the care which is available within the NHS?
Yes, Ajit. For your question, we will utilize joint budgets and resource allocation theory to prioritize funding for high impact prevention services that reduce long-term demand. To build trust and reach, we will engage vulnerable populations in service co-design and co-production, ensuring pathways are culturally appropriate and physically accessible. Is it satisfies you?
Yeah, definitely. So what I feel is we should make them involved in the part of the working group
Yes.
so that they feel they are part of the thing which is happening, and they feel wanting the need to contribute, as well as they feel they can trust the system which is giving them the quality care and treating them in a fair way, and there is no disparity between the other groups. Is that what you are referring to, Mr. Kesavan?
Yes, Ajit. Absolutely.
Yeah. So
And
thank you for
we are
this
coming to the
wonderful.
end.
Yeah, please go ahead.
As we are coming to the end, um, as we talked about all the recommendation strategies and the key challenges that we face in our roles, we all gave an helpful recommendation to the Hertfordshire community that will help many peoples to gain more healthcare services, also improve people's healthcare. Thank you.
Thank you, one and all, for this wonderful opportunity. It was a pleasure meeting all of you in this auspicious.
Thank you, everyone.
Thank you, everyone.
Thank you.